Hello, everyone. Hope everyone's having a great day. We tonight are going to be talking about hormones and hearing about how we at Lyra work to make sure that they're optimized as all of us age, and of course our hormone levels drop over time. So excited for you guys to dig into this topic tonight with Mark and Lynn. Before we hand it off to Mark, Alex, if you can hop on and just tell everybody what's going on with the wearables, and just that'd be great.
Sure, no problem. So for those of you that have already filled out the wearables survey, you should have gotten specific comms to the device that you're using. That should be in your email as of yesterday. What we asked for essentially was just your version of the monthly reports for whatever wearable you're wearing. So in the next couple days, if you can get those into us at beta@lyrahealth.com, that would be great. If you have not yet told us what wearable you're wearing and want to do so, it is not too late. You can still use that wearable survey email link that's in the communication that we sent, or you can just email us at beta@lyrahealth.com. Tell us what wearable you are using, and we will get you what you need to get on your way.
Thanks, Alex.
No problem.
All right, let's jump in. Mark, I think you're starting this off. Is that right?
That is right. It is me.
Excellent. Thanks, Mark. Okay, here you go.
So you're going to control the slides, and I'll just tell you, Jenny.
Yes, correct.
All right, cool. All right, let's get into this and not waste any time here. So go back, Jenny, to the first one. So the other way. So obviously, this first slide seems simple, but I want to dig into this slide for a minute and just make sure we know where we're at here. It says hormones and how to optimize them as we age. When you go to a conventional doctor, what they're really looking for is that defensive medical approach, as we've talked about on the first time that we had a lecture here or a talk. And as an integrative doctors, and what Lyra is trying to do is we're trying to optimize. So there's a huge difference between just letting someone limp through menopause or just accept PMS or to accept a suboptimal thyroid gland or a suboptimal adrenal gland. We're going to optimize it. So when you go to a conventional doctor and you're saying, I'm tired, I don't feel well, I have hormone problems, they're just going to do the bare bones minimum to make sure you're not going to die or you don't have a horrible medical problem. We're looking at that as Lyra as the exact opposite. We're saying, how do we optimize this? How do we make you age properly and well? So I want to make sure we understand that's really what we're coming from this. So next slide. So, and this is iceberg picture again, and at the main root causes of diseases and problems and feelings. So obviously, this is pretty high up on the top of that iceberg is a hormonal imbalance or deficiency. So that's where we're at today. So next slide. So it says the Lyra method, how we evaluate your hormones. I mean, there's so many questions we ask you that we actually had to do 2 slides here to have it all in there. So we can go through each of these, you can read them, but obviously we're looking for these clues that have a lot to do with your hormones. Disturbed sleep, having that second wind or this night owl kind of thing that people have in the evening, low energy, stress, low sex drive, mood issues, hard time focusing on tasks. Next slide, Jenny. And then a few of those just obvious hormonal questions: PMS, menstrual cycle irregularities, hot flashes, and then some other what we would call thyroid symptoms: hair loss or thinning, constipation, problems losing weight. So lots of different questions because we really feel this is very important. Next slide. And, as far as the testing goes, as far as what you had, when we use the word baseline, that's the testing you guys have already had. So that's a comprehensive thyroid panel, and we'll talk about what that means today, including the thyroid antibodies. And then men and women are getting a baseline testosterone level. The advanced testing, which you guys haven't had at this point, is either saliva testing for some of the female hormones for premenopausal females, and then so you can do blood testing on postmenopausal females. Obviously, males aren't there because the main hormones are the testosterone, which we're already getting on the baseline. Next slide.
Mark, I was going to say for male, we do actually have an advanced male. If they just they're
right.
interested. Okay.
You're right. You're right. Yep. Next slide. And obviously just the goofy legal thing here where the rest of this talk is going to be a little bit more like how do we fix these problems and whatnot. So we're just trying to be as legal as possible here, understanding that you should talk to a LYRA practitioner or your own or primary care doctor before doing some of these things that we're talking about. Next slide. So most people have probably heard about the pituitary gland. If you haven't, that's okay. But the pituitary gland is a dramatically important organ in the body, and it's located right here, a little bit deeper in. That's obviously a side picture there of the pituitary gland. And obviously, we're calling this the maestro of many different hormones. This pituitary gland is so important is that that's why some cultures put a dot on their head right here. The dot is there because some cultures call it the third eye. And that dot is protecting that third eye. So it's such an important part of the body that there's many different ways of thinking about how instrumental this organ is as far as all of life and aging and health. Next slide. So this is a busy slide that just shows a blown up picture of that pituitary gland right in the middle. And then look at how many things that this pituitary gland is talking to. It's called the maestro because it's talking to all these different organs. So going around the clock, so to speak, starting at like 9 o'clock. So it talks to your adrenal gland, it talks to your bones and muscles with growth hormone, it talks to your skin, it talks to your thyroid, it talks to your sex glands, it talks to in the female, the breast. And then it even talks to the kidney to have how you hold on to water and how you stay hydrated. Next slide. So the big, huge distinction that I was also trying to introduce earlier is the word hormones. And a lot of people, I would say most people would say when you hear the word hormones, you think of testosterone, estrogen, progesterone, like the sex hormones. But that's not really what LYRA means. What LYRA means is that we're looking at the big three. So it's the adrenal gland, the thyroid, and then the sex hormones. And we're going to talk about the interplay of these three glands and how this hormonal balance is needed, optimizing each of those, and then the balance between the three of those. So next slide. So let's start with the adrenal gland. So the adrenal gland is like the engine of your car. It's also like the cell phone battery of your body. It produces many different things, and we're not going to get into the geekiness of that, but its main hormone is cortisol. But look at all the different symptoms of that cortisol dysfunction that we have here. Poor energy and stamina, disturbed sleep, problems in balancing blood sugar, blood pressure, and fluid. A lot of people who get dizzy when they stand, one of the roots of that is its weak adrenal gland. Craving salt is a definite tip off to an adrenal gland problem. And hugely this post poor recovery from exercise. So like going to like an amusement park and then having to be in bed for 2 days or being so exhausted, that's an adrenal problem. And then even depression or anxiety or even menstrual irregularities can be caused by the adrenal gland. Next subject and next slide. So your adrenal gland it's such an elusive gland to test, to look at, and to talk about because it changes every hour. And so your adrenal gland is like the cortisol in your body is like a ski slope, and it's supposed to start high in the morning and then come down at night and then come back up. And this is a beautiful graph showing that at the different times and when it's supposed to be high and low and doing that. And as we're going to show you, it can definitely get all wonky and off and problematic. Next slide. So this is how LYRA measures cortisol through how we're going to measure cortisol through the saliva cortisol testing. And this is when you provide 4 saliva samples, usually right when you wake up around noon and around 4 or 5 o'clock and then around bedtime. And it's incredibly powerful testing. And it's so amazing to talk to people and show them the graph and to show them what's happening throughout their day. And more often than not, when it's off, the person's like, well, that's exactly when I have to drink coffee, or that's exactly when I have to have sugar, or that's exactly when I feel depressed. So this curve is actually pretty good. Those 4 dots, you see those 4 black dots, that's someone who feels pretty good in the morning and pretty good, maybe a little bit low at 6 o'clock or so. But you'll have people sometimes, well, they'll have a morning cortisol that's perfect, but their noon is like so low it almost isn't even on the chart. So that's why we have to do the saliva testing, mostly because you can't go to LabCorp 4 times in one day, and LabCorp's not open at bedtime. Next slide. So what I was talking about, that's exactly what I was talking about how it can be low or high, and it can be all low or all high or all over the place. But here are some common patterns. The cortisol can be too low. The cortisol, which we would call adrenal fatigue, which I know is a very integrative topic, yeah, it's an integrative phrase that a lot of doctors don't believe in. And then the cortisol can be too high, which is what I think we're going to call fight or flight, which is what a lot of people feel, that all that adrenaline, adrenal, the first 7 letters of adrenaline is adrenal. So that's like adrenaline. And then this wired and tired too. And that's sometimes it's part of all of this as well. And then definitely the cortisol getting that second wind. A lot of people just say, "Oh, I'm just a night owl. I'm fine." That's not normal to get this second wind. It usually happens around 10 p.m. is when most people get this second wind. And that is not a normal thing. That is a cortisol spike, that happens at night. Next slide. I should go back. Well, actually, let's just stay there. So a quick personal story about my journey with this and why I really want Lyra to be as much in the adrenal gland as we can be. So when I went to medical school, I graduated from Georgetown Medical School. And when I graduated, when I was a resident doctor, I one day was going for a jog, and I wanted to finish my jog and read a book. And my whole goal was to just not read anything about regular medicine and was to read about something integrative. And I went to Barnes and Noble or whatever, and I got this book. I just randomly found it. It wasn't like I was searching out for it. It's called Adrenal Fatigue, the Disease of the 21st Century Stress Syndrome. And when I ended up reading the book and getting through the book, I started crying like a baby. I was like, and why I was crying was because literally I had every symptom of adrenal fatigue, like every single symptom. And, being a resident doctor, you don't sleep every 4th night. Med school's pretty stressful before then. And one of the reasons why I was crying was also because I just went through med school and paid $300,000 to go to med school, and no one ever taught me that what was wrong with me. And I just thought it was normal to feel that bad. I thought it was normal to wake up super tired. I thought it was normal to have a second wind at night. And then I started doing all the things in this book, and I felt 100 times better in about 4 or 5 months. And I didn't even know what I was doing, and I was still stressed out doing that stuff. And so it's such an interesting subject, and mostly because regular doctors don't believe in this. This is not something that the conventional medical world believes in, and mostly because it's really hard to break your adrenal gland. Can you go one more slide up, Jen, or backwards? Yeah, that slide. So in this slide, you guys see at the beginning, it says cortisol's too low, not Addison's disease. Well, the conventional medical doctors only care if it's Addison's disease is when your adrenal gland breaks. It's incredibly hard to break your adrenal gland. The only person that you guys probably have known that has broken their adrenal gland is JFK, who had Addison's disease. And then, the cortisol being too high, it's not Cushing's disease. It is incredibly rare to have Cushing's disease, which is a tumor or a severe problem with your adrenal gland. But I bet you half of you out there have high adrenal cortisol at some point. So it's that different approach that Lyra is going to take versus what a conventional doctor is going to take. Okay, next slide. So then when it gets to cortisol optimization, and like basically half of this book is basically really boring stuff, but we want to make it at Lyra not boring, and we want to prioritize that for you guys and understand how important it is that when you put all these things together and you avoid caffeine and sugar and switch to a whole foods diet and prioritize the sleep and rest when you feel tired and exercise in moderation and do meditation and mindfulness and do things like acupuncture massage, you can heal your adrenal gland. You can get your energy and stamina back, and you can make a lot of those symptoms go away. Next slide. But there are ways of, and this isn't cheating, but there are ways of helping. It's just no drugs. There's no medications that can really help the adrenal gland. There's medications for the adrenal gland that will hurt the adrenal gland, but there's no medications for the adrenal gland that will help it. So a lot of times we wrote here, if the cortisol is too low. So the word adaptogenic is a really good word. So adaptogenic means there's herbs that adapt to you. So if your body is low, it will make it high. And if it's high, it will make it low. But we're saying here, if cortisol is really low, we want you to take specific adaptogenic herbs. And these are the four, the ones that we see work the best are these four. Next slide. And the cortisol being too high can be helped by those herbs on the previous slide. But when the cortisol is too high, especially at night, phosphatidylserine is amazingly safe, wonderful amino acid that helps bring down that cortisol. And then the banana leaf. And then there's ashwagandha again, which was in the previous slide. Next slide. All right, now we're moving on. So the adrenal we call the engine, and the thyroid is the gas pedal. So the gas pedal and the thyroid, it's a much sexier topic, and it's a much sexier topic because there are prescription medications for the thyroid. There's also great herbs and great treatments for your thyroid, but the thyroid is it's such an important organ because it dictates so many things that a lot of people care about on their daily basis. So cold hands and feet, the most important classic symptoms are cold hands and feet, dry skin, brittle nails, hair loss, and a really interesting one, if you have eyebrows on the last third that are really thinning, that's very indicative of some level of a thyroid problem. Obviously, weight gain or trouble losing weight, fatigue. The thyroid is the governor of your digestion and motility, so constipation definitely can be related to PMS and menstrual irregularities, and definitely depression and low mood can be a thyroid problem. Next slide. So how does Lyra measure thyroid function? So that it was a big part of the testing you guys already have. So we tested the TSH, which we can go through each of these things. It's a little boring, but it's the hormone that the pituitary made, which was on one of the first slides. And then we're actually checking both forms of what the thyroid makes. The thyroid makes T4 and it makes T3. And in a slide in a minute, we're going to show you that my analogy or Lyra's analogy is T4 is like a school bus, and T3 is like a Corvette. And you can read there that the thyroid produces a lot of T4, but this conversion of T4 to T3 is what we're taught in medical school works perfectly in everybody. But that is what Lyra is about, is trying to optimize that T4 to T3 conversion, which thus optimizes your thyroid. But we're checking your T4 and your free T4 and free T3. And what's crazy is that regular doctors only check the TSH. They actually sometimes will check the T4, but not the free T4. And obviously we like checking the free T3 and the free T4 because that's what's free to your body and what's free floating around. And that's why we wrote at the bottom, your PCP can only check TSH and sometimes this, but and they'll really never check the Hashimoto's antibodies, which we'll talk about in a minute. Next slide. So we're measuring Hashimoto's antibodies. And that's basically like a little teeny version of lupus at the level of your thyroid. We measured two of them, the thyroid peroxidase antibody and the anti-thyroid globulin antibody. And we can talk about on those slides what these really mean, but that's not really as important as understanding that. So the sequence of events is really crazy. Like a regular doctor is taught in school to only check the thyroid antibodies if the thyroid is hugely swollen and they don't know what's wrong. But in reality, they don't even do that because they're only going to treat you with medication if your thyroid breaks, and they're only checking the TSH. So if your thyroid's broken and it's swollen, they're going to treat you the same as if it's swollen and the thyroid's normal. They're only going to treat if that level's off. So we've had people, you can have a thyroid problem and be on thyroid medication for 20 years and had Hashimoto's and no one ever told you that you did. But you can also have Hashimoto's and have a normal thyroid function on lab testing, because I think we talked about in one of the previous lectures that no, we didn't. That Hashimoto's is like having a little teeny ice pick at your thyroid, and it's ice picking your thyroid. And so if you're having normal thyroid function but Hashimoto's, it means that you've only had a little bit of ice picking. But what's the whole point of this? Is that what Lyra is hoping to do is not only detect that, but to put you in that bucket that you have an autoimmune disease. So if you have an autoimmune disease, we want to find the root cause of that. You know, is it a toxin you're being exposed to? Is it an infection? Is it a food that you're eating? Because you know that gluten and gluten sensitivity is proven in the literature to be connected to Hashimoto's. So the point is that this Hashimoto's testing is so cool because it gets you so many different things. It gets you, oh my God, I have an autoimmune disorder. I need to fix the root cause of that. But it also shows us that you need to really focus on what your thyroid's doing because it plays such an important role in the rest of your health. Next slide. And then, you know, when it comes to either medications for your thyroid or thyroid optimization, there's a lot of different ways to optimize your thyroid. So we can go through some of these, you know, iodine-rich foods. You know, when we check T3 and T4, some people think that means 3 thyroids and 4 thyroids. Really, what it means is a tyrosine molecule with 3 iodine molecules wrapped around it, and then T4's tyrosine with 4 iodine molecules. So getting in some iodine, if you have a thyroid problem, can help, but you can use too much, so you have to be careful. That's why we're only recommending very minimal amounts: seaweed, salmon, iodized salt in moderation. And then the big ones are the next two. The selenium and the zinc are hugely important to convert that T4 to T3. And the analogy that we use is that in the human body, there's a body shop. And the body shop takes those T4, which are Corvettes, which I said before, school bus, which I said before, and it actually converts it into that Corvette. And that conversion of T4 to T3, and I'll repeat myself from earlier, is a huge part of what Lear is trying to accomplish and to look at with you guys. And that can actually be helped with selenium and zinc. And a lot of like pumpkin seeds, oysters, shellfish, legumes have some of these things in them. And then there's that word ashwagandha again. You know, we talked about with the adrenal gland. It's such an amazing herb because it helps so many things being adaptogenic. And here are some of the other herbs on that list that help. And then, you know, vitamin D just does so many different things, but it's also definitely connected to autoimmunity and connected to autoimmune thyroid. And then obviously trying to eat as healthy as possible to not irritate your immune system and your body to have problems with your thyroid. And then because your adrenal gland is the engine and the thyroid's the gas pedal, the more stress reduction you have, the more you help your adrenal, which helps your thyroid. The next slide. So what if you need thyroid medicine? So this is when I was saying before, the school bus and the Corvette. There's the T4, you know, and there's the T3. And why we're also bringing this up is because conventional doctors only prescribe levothyroxine or Synthroid, which is that first little bullet point there, where integrative doctors and Lyra can prescribe can prescribe some thyroid medication if you absolutely need it to help that T4, T3. We would rather you do this naturally, right? Lyra would rather you get your T4 to get converted to T3 naturally. Even if you're already on Synthroid, we want you to help that conversion to T3. So that's why the testing is so important to be able to figure out where you guys are at. Next slide. And that's it for me. So Lynn's going to take over and talk about the female hormones.
All right, thank you, Mark. That was awesome. All right, ladies, it's time to talk about our hormones. And I want to start just by orienting us with what our hormones are doing throughout our whole lives. I think this is a really important graph that really dictates how we feel pretty much throughout our entire lives. So if you take a look at, this is what a normal female menstrual cycle looks like. And the red line there you'll see is estrogen. And the yellow line there you'll see as progesterone. And then you see the blue line kind of skating across the bottom, that's testosterone. And that doesn't really change all that much throughout our cycle. Other than you see there's a little blip in testosterone around day 14, which is when we ovulate. And that's just for evolutionary purposes, because that's when we want to procreate. If anyone has ever felt like they have a higher libido mid-cycle, that's why you get that little boost in testosterone. But really the most important thing that I want us to focus on is that second half of your cycle from the time you ovulate to the time you have your period, which is called the luteal phase. So if you notice, again, this is a regular looking female menstrual cycle. Progesterone and estrogen are kind of going in sync and they look fairly regulated and balanced. But what happens to a lot of us is that progesterone piece falls much lower in that second half of your cycle. And imagine if this graph to look like the estrogen was still where it is, but that yellow line was much lower. And it's that gap between estrogen and progesterone, usually during that week to 10 days before a period starts, that we would call PMS. And that's when we feel pretty lousy. You could switch the slide, Jenny. So just give me a shout out. Yes, that's me. If any of my ladies out there have ever felt any of these symptoms before their period. Yes, anyone? Is anyone out there? That's okay. Well, I have. I've definitely had. Thank you, Jen.
Too many
I've
years.
definitely. What's that?
I think it's been too many years.
It's been too many years. Is everybody out there postmenopausal? I don't even know. Maybe we're getting to you in a moment. But yeah, I mean, I remember the years when, I would actually plan activities around when my period was about to start because I knew I was going to feel so awful. I didn't want to plan anything super important beforehand. So these are just a few: mood swings, low libido, headaches, food cravings, night sweats, acne, insomnia, tiredness and fatigue, and weight gain. And that's again because of that gap between estrogen and progesterone that happens right before your period starts. Next slide, please. So if any of you have those types of symptoms, Lyra has the ability to kind of capture that imbalance using saliva. It's pretty hard to see this slide, but basically what we're going to be measuring is a saliva estrogen level and a progesterone saliva level during that day 19, 20, 21 of your menstrual period. So we're going to capture what those levels are during that all-important luteal phase of your cycle. And most of the time, if you've got those types of symptoms, we usually are going to find that the progesterone is in fact deficient and you do have that hormonal imbalance going on. Next slide, please. So this is maybe what y'all are experiencing out there, and that is the perimenopausal, menopausal transition when the estrogen levels start to drop. And that can happen anywhere, usually somewhere in your 40s, 5 to 10 years before your period actually stops. You start to go through what's called perimenopause when your hormone levels change. And perimenopause can be very rocky because there's a lot of ups and downs in your hormone levels from month to month. So some months may feel fairly normal and other months may feel fairly terrible. And that's because your ovaries can't really decide what they want to do. Some months they might even put out more estrogen than ever. At the same time, you're not producing as much progesterone anymore. Usually because you may not be ovulating anymore and you need to ovulate to produce progesterone, or the eggs are older, frankly, and they don't put out as much progesterone as they used to, or we all have chronic stress in our life, which depletes the progesterone even further. So the point is that that gap gets wider and there's swings up and down from month to month. You may start skipping periods, skipping altogether, and then it may come roaring back. And this back and forth and up and down roller coaster that you're on can happen for months. Sometimes ladies even go through it for years before they actually have their last period. You're not considered actually officially done, or what we call postmenopausal, until you go an entire year without having your period. Next slide, please. Here's a brief list, a short list of some of the symptoms associated with going through this transition. And what still surprises me to this day is how wide and varied these symptoms are. And some of them you would have no inkling that they have anything to do with hormones. For instance, just body aches and pains, skin changes, digestive system symptoms. For me, I had those mood issues, irregular heartbeat. A lot of women have that change in their heartbeat, their heart rate. So just a lot of weird symptoms that start to happen that you would have no idea have anything to do with your hormones, but it's because the hormones are going up and down, and then they're finally really low, and you get a lot of deficiency symptoms. Next slide, please. So how we check this is some of this we get through the baseline labs, but we have an additional advanced female hormone panel to really get at where you are in this process. one of the main things that can tell us that is FSH, follicle stimulating hormone. That's one of those hormones put out by the pituitary gland that Mark mentioned a few slides ago. It's basically your brain talking to your ovaries, telling your ovaries what to do. So the higher FSH goes, it's basically trying to tell your ovaries, please come on, make more estrogen. We can't be done. We can't be done. So FSH goes high as your ovaries start to get a little sluggish. So if we see a high FSH, we know you're close to or at the menopausal range. And again, estrogen is going to start to decline. So if we see levels below around 20 or so, that's my rough estimate as I've seen and noticed over the years. If it's below 20, that's when I start to have my patients really start to get symptomatic with the things like hot flashes, night sweats, vaginal dryness, those types of symptoms. We also look at sex hormone binding globulin, which is a protein that binds to testosterone. Like I said, testosterone kind of stays steady-ish throughout your normal menstrual cycle, but we're going to talk about that in a minute. It starts to decline in your late 30s, early 40s. And if you have high sex hormone binding globulin, it makes it even worse because it's kind of binding up all your testosterone, so you have even less available for use. DHT, dihydrotestosterone, is high when people might have hair loss from this. So high DHT is your testosterone converting into DHT, which is associated with hair loss or hair thinning. And then DHEA is an adrenal hormone. It's a precursor to cortisol, testosterone, and estrogen. It declines as we age, so we're checking that as well. Next slide, please. So there are things that you can do to support your hormones naturally, whether you're going through just PMS symptoms, PCOS, endometriosis, or perimenopause and menopause. There are definitely things that we can do to make this transition easier. And some of them are going to sound like, oh my God, there she goes again, talking about diet and exercise and sleep and stress. But the reason we keep coming back to this and all these topics is they are so important and foundational to all this. And yes, definitely hormones. So ensure you're getting enough protein. Protein is really important for us ladies as we age. We lose muscle mass pretty quickly, and we need to make sure we're getting enough protein in order to maintain our muscle mass and our hormones as we age. Swap out carbs for healthy fats. There's lots of reasons for this, but in the context of hormones, you need fat to make hormones. So fat's not the enemy, especially when it comes to hormone production. Engaging in regular exercise helps a lot of things, including keeping your testosterone level up, but also reduces PMS symptoms and helps clear out extra estrogen in those cases where people are making too much, or in cases like endometriosis, where you're just making too much and holding on to it too long. Maintaining an optimal weight is helpful. Prioritizing sleep. We always talk about aiming for 7 hours. Avoiding sugar and alcohol, which absolutely I can tell you, I've multiple stories about, personal stories too, about how alcohol and sugar without a doubt make hot flashes worse. And stress also makes hot flashes worse. So we talk about incorporating those stress reduction techniques like mindfulness and meditation. Slide, please. So there are some vitamins and supplements that you can do to help throughout this process as well. My favorite by far herb for PMS symptoms is called Vitex, otherwise known as chasteberry or chaste tree. It doesn't change your actual progesterone levels, but it does a really good job of helping eliminate some of those PMS symptoms. It works really well. There's really no downside or side effects to taking it. And it's my go-to product if I have any patients with PMS for sure. And then good old vitamin D3. We talked about this before. It's considered a pro-hormone, so it helps you make more hormones. I've had patients who all I've done is get their vitamin D3 at an optimal level, and their PMS symptoms get dramatically better. So all throughout your hormone life, it's important to get that vitamin D at an optimal level. DIM is another tool that I use for hormonal imbalance because it's the flip side of Vitex. You think of Vitex as supporting the progesterone pathway. DIM kind of helps excrete that estrogen. So that, again, there's two sides of unevenness, right? They've got to boost the progesterone or decrease the estrogen. And DIM is a compound found in cruciferous vegetables that helps your liver detoxify those extra hormones in a healthy way. And then in some cases, we can actually use just over-the-counter progesterone cream. These are derived from plant-based sources like yams, and you can rub it on your skin during the second half of your cycle to kind of mimic what you would like nature to be doing to kind of boost up those levels in the second half of your cycle. So if all that fails and you are still very symptomatic, and this would be talking to the postmenopausal women, what about hormone replacement? So we could probably spend, have an entire workshop or lecture on just this topic. You've probably heard of synthetic hormone replacement back in the day called Premarin or Prempro. In the early 2000s, they came out with a study that showed that actually increased a woman's risk of breast cancer, dementia, stroke, heart disease, blood clots. And after that, hormones kind of fell out of favor because everybody associated them with cancer and they were bad. So women were just left to suffer and say, okay, it's menopause, suck it up. There's nothing you can do about it because hormone replacement is not safe for you. But there is an alternative called bioidentical hormone replacement, or BHRT. And it's called bioidentical because the hormone compound, the hormone molecules are made in such a way to look just like your own hormones do. It's kind of like a key that fits into a lock just right. So they make the key to look like the hormone receptor needs it to look. So that fits just right. And they don't carry the same side effect profile or risks that the synthetic hormones do. And so there's no hormone that's zero risk. Even your own hormones can flare or contribute to certain types of breast cancer. You might have known women who have had what's called estrogen receptor positive breast cancer. That's when even her own hormones are flaring that particular type of breast cancer. So even bioidentical hormone replacement has to be done in the right setting, in the right way, smartly, at the lowest effective dose for the shortest amount of time. And there's a position paper that came out recently by the North American Menopause Society that basically said, you know what, the benefits of hormone replacement outweigh the risk for the vast majority of women out there. And the most benefit is conveyed if you start within 5 years of going through menopause. And as long as you're under 60, the benefits outweigh the risks. Now, what's that magic age of 60 about? There really is no magic age about 60, but it's at 60, you should really start to ask yourself, do the benefits still continue to outweigh the risks? I have many patients who are on hormone replacement well into their 70s. My oldest is 90. She swears she's 90. She made it to 90 because of her hormones. She might be right. There's many, many benefits to them for the obvious reasons for symptoms. I have some women who do it just to control symptoms because they're miserable without it. But I also have a lot of women who choose to do them just for the healthy aging benefits. We know that your bones need hormones. We know that your brain, it feels better on hormones. There are many studies that show that dementia risk is increased when hormone levels are low. So there's lots of healthy aging benefits to hormones that has nothing to do with hot flashes or night sweats. But it's a personal choice. All the risks should be weighed given your specific situation. There's no one size fits all answer to this. But if you're going to be doing any type of hormone replacement, it should be bioidentical hormone. It should be using the skin as the delivery mechanism for estrogen for sure. The lowest effective dose, preferably as soon as you go after menopause as possible. And after the age of 60, you just have to still keep evaluating if the benefits are still there for you. You can get BHRT at any regular pharmacy. We use the estrogen patch and the progesterone pill most commonly. And if any of you are interested in that, you can have a consult with me after you do that advanced female hormone panel, and we can talk about what options may be best for you. Slide, please. All right. Testosterone. So this is the last hormone. Both men and women need testosterone. Guys, they think that it's only a guy thing. And a lot of primary care doctors out there will not even talk to women about testosterone. It's just one of the many ways we get the shaft about a lot of things. But we need it too. You saw that curve that I showed you a few slides ago. We have it throughout the whole month. And after menopause, it does decline, and we can feel the effects of that. Men and women can feel the effects of testosterone deficiency. Some of them are listed here, that fatigue, irritability and depression. The most obvious one is low sex drive, poor exercise, stamina, and recovery, decreased muscle mass, and a lot of mental clarity, focus, attention, staying on task. And our bones, our osteoporosis risk is also increased due to low testosterone. Interesting studies I mentioned earlier about low testosterone levels being associated with a higher risk of dementia and cognitive decline. Slide, please. So there's some things that you can do to support your testosterone naturally. The number one cause of low testosterone level in men and women is stress. And we talked about this a lot last week, about how stress makes us focus on survival and who cares about having sex and procreation. So your testosterone levels are downregulated under times of stress, whether it's acute stress or chronic stress. So having those stress mitigation strategies that we talked about last week can actually help bring your testosterone level back online. Exercising regularly can boost testosterone. Weight training and high intensity interval training have been shown to be the best for this. And maintaining a healthy weight, being overweight or underweight, can negatively impact your testosterone levels. Next slide, please. And this is just a slide that shows the foods that you can use. You know, I think food is medicine. So whenever we can choose foods that help us, all the better. And here's just a list of foods that you can choose that have some specific components in it that could be helpful to you. Basically, we're looking for foods that are high in protein, provide us healthy fats. Zinc is a fabulous way to increase testosterone. Foods that contain zinc are helpful. Selenium, again, ginger, and allicin, which is found in garlic. So this is just a list that can show you the different ways that you can use foods as medicine in the case of boosting your testosterone. Next, please. And then some natural testosterone support in the form of supplements. Here's our friend ashwagandha again. It can actually boost libido, improve your mood, and mitigate stress. It doesn't directly increase testosterone, but it has been shown to boost libido. Vitamin D3, we've talked about that before too, as being a hormone. Therefore, it's really important to optimize those levels to help us with the hormone production process. Maca is an herb, again, that doesn't directly increase testosterone, but may help boost your libido. And omega-3 and fish oil are important because we need fats to make any hormones, particularly testosterone. Next slide. All right, so what about testosterone replacement? Men have a lot of options. Again, it's routinely checked by primary care doctors or urologists, and men have 3 basic ways to do it. You can rub a cream on your skin. You can do shots either weekly or bi-weekly, or you can do something called pellet therapy. At the bottom right of the screen, I don't know if you can see it, is an example of little pellets that we do. And it basically looks like a little picture, like a grain of rice. It gets implanted under your skin into the layer of fatty tissue, and they slowly dissolve over time over a period of about 4 to 6 months. So that's a really efficient way to do testosterone replacement because you don't have to remember to do anything. You just go to someone's office who puts them in and you go about your way. For women, it's a little bit harder because first of all, you have to convince somebody to check it, which Lyra does. We think it's really, really important. And then you have to get somebody to actually know what to do about it. And it's a little bit harder because you can't get testosterone at a regular pharmacy like men can. There's really only 2 options. Number one, you can get a compounding pharmacy to make a cream for you, or you can also do pellets for testosterone. So again, we at Lyra check it because we think it's so vitally important for a woman's health too, to have testosterone be optimized. Okay. We're done with the knowledge portion of this, and now we're going to take a quiz. So hopefully y'all have been paying attention. We've got 5 quick questions to ask, and we're going to do a poll like we did. I don't know if you were here in week whatever when we talked about foundations. So we're going to ask the question, and then Alex is going to pop on and tally the results. See if you can get all 5 of them right. And here we go. First question. Which gland or hormone is like the engine of your car? Is it testosterone, thyroid, the adrenal cortisol, or estrogen? Please go ahead and cast your vote. We really need some music for this portion.
I was thinking the same thing. Give it a couple more seconds. All right, here are the results.
All right, we have a winner, adrenal cortisol. That's right. That's what Dr. Severi referred to as the engine of your car. It gives you your energy and your stamina. And for those of you who said thyroid, that's a close second because thyroid is the gas pedal. Next question, please. All of the following are symptoms of hypothyroidism except we've got constipation, fatigue, vaginal dryness, weight gain, or trouble losing weight.
Any other votes out there?
Take a guess.
All right, here we are.
All right. Yep. The winner is vaginal dryness. Vaginal dryness is more a symptom of low estrogen. So that's one of those estrogen deficiency symptoms. This was a kind of a trick question because for those of you who said weight gain or trouble losing weight, I mean, there's some overlap between all these hormones. And that's what Dr. Severi was saying in the beginning. A lot of them do more than one thing. But weight gain and trouble losing weight is a pretty common symptom of hypothyroidism. Next question. All right. PMS is primarily associated by an imbalance between which two hormones? Cortisol and thyroid, testosterone and dihydrotestosterone, estrogen and progesterone, or estrogen and testosterone.
All right, here's our results.
All right. The answer is estrogen and progesterone. So this goes back to that graph that I showed where the estrogen and progesterone have to be in balance during that luteal phase. If not, that's what creates that PMS type symptoms. Question number 4. This one's a giveaway. If anybody gets this wrong, our diets and the food choices we make every day have a huge impact on our endocrine system and all of our hormones. True or false? Yay! Absolutely. I sound like a broken record, but what we eat, the lifestyle choices we make affect everything, every single topic we talk about every week. And food is medicine, and you can do a ton simply by changing your diet and your habits. All right, last question. Which herb is potentially beneficial to your thyroid function, your testosterone levels, and the stress response through its impact on cortisol pathways? Which herb can do all those things for you? This is a tougher one. You got to be really paying attention to catch this one.
Yeah, we've got some confident voters here.
All right. Oh, yay. That makes me happy because that makes me think everybody was listening. Thank you so much. Yes, we talked about ashwagandha all throughout this presentation because of how versatile this herb is. And this shows up a lot in our recommendations for all of you because of that reason. All right, very good. That is it for tonight. Is there any questions that anybody has about anything we went over tonight or anything hormone related?
There was a question in the chat, Lynn, about HRT and asking if you will address the HRT benefits years after menopause. This person's wondering if it's helpful, especially in the absence of typical menopause symptoms.
Well, that's a great question. I guess part of me would want to know, are you talking about someone who's never been on hormones and then wants to start several years afterwards? Or have you been on hormones the whole time and you're just asking about if it's okay to continue? That would be one question I'd have. But in general, I would say absolutely the benefits continue way beyond that 5-year window or even beyond 60. And as long as we're doing it smartly, as long as we're doing it safely, as long as a woman is continuing to get regular breast cancer screening, as long as we continue to monitor her health and we're not overdosing or, being overly aggressive with how we're administering it, then I have absolutely no problem keeping my patients on hormones long after menopause. But again, it's an individual choice. I would have to know each person's individual story and individual risks, and we together could make that decision. But I definitely have many women, like I said, in their 70s and 80s still on hormones. Hopefully that answered your question.
Yeah, thank you, Lynn. This person was specifically speaking about someone who has never been on them.
Okay. Yeah, I mean, I think we would have to sit down and talk about the reasons. Is there specific risk factors that you have that you were working on? For instance, I could make the argument that if someone had a very strong family history of dementia, there's still probably benefit, even if you've never been on them before, or if your bone health is a concern to you, there's benefit, even if you've never been on them before. We would just need to weigh what other risk factors that you might have and make sure it was a good fit for you. And like I said, just be very smart and conservative with our dosing, but we can certainly sit down and have that conversation.
All right. So, Lynn, do you want to just talk about next steps if anyone is interested in the advanced testing? And, this is all covered in the PHPs. But...
Yeah. Most of this is covered in the PHPs. If you've had a visit with me already, we've probably talked about this. If you haven't, or even if you have and we didn't talk about it and you want to revisit the topic, that's fine too. But the next steps would be either if you're still getting a menstrual cycle, if you're still premenopausal, you're still getting your period, we would want to do that saliva test to see where you are, to see what type of imbalance you may or may not have and how bad it is. If you are postmenopausal, then you would do the advanced female hormone which is blood work through LabCorp, because that's going to get your estrogen level and your FSH. So we'd have that starting point. In either case, we need that starting point. We need to know what we're dealing with so we know what level of imbalance or deficiency we're dealing with. So that would be the next step, would be to do the advanced testing. Then everybody who does advanced testing gets a consult with me to review your results. So during that consult, we'll go over it, and then we can decide together. We can talk about, again, these individual risk factors and what's appropriate for you, and we'll make that decision together. Anything else? Oh, I'm sorry. By the way, one more thing, just to clarify. Testosterone, you really don't need any other testing for, because that's done in the baseline testing. So if someone out there who may be interested in testosterone, we already know what your levels are from the baseline testing. And if you've had your PHP visit, you again would be recommended to have a chat with me if that's something that you're interested in. If you haven't had your PHP visit yet, then we'll talk about it then, and then we can set up that next consult. But that we already know from the baseline testing.
But Lynn, that's not the case for men.
Well, we know what their testosterone level is.
Yeah. But we want them to do the advanced test just to check their PSA, right?
Yes. There's that one extra layer for men. If you are interested in pursuing actually getting testosterone, there's one more step you have to take, which includes the PSA level. So there is more. Thanks, Jenny, for reminding me. We always forget about the men and their extra testing.
All right. Well, thank you, Lynn and Mark. Very, very helpful. Hope everyone has a great night.